at 3 o'clock. Good afternoon and welcome to today's briefing. Fellow Kenyans, we want to thank you for joining us again this Saturday for this Saturday briefing on COVID-19 situation in the country. As you have been following from our daily updates, the infection rates continue to rise daily as we continue to get results from numerous testing centers spread throughout the country. Over the past few weeks, the reality of COVID-19 has hit home. Our brothers and sisters are losing their lives, and many more are in hospital. As we have been sharing, and now must do so with emphasis, sadly, out of those who have died, over 50% had pre-existing or underlying conditions. As you have heard us say here repeatedly, a number of non-communicable diseases are these pre-existing conditions, and they dispose one to an outcome of COVID-19 that might not be desirable. Diabetes is a risk factor for hospitalization and mortality from COVID-19 infection. Studies conducted in China, for instance, indicate that patients with severe disease, up to 16% had diabetes. Also, diabetics are twice as likely to require intensive care than COVID patients without diabetes. Diabetic complications such as diabetic kidney disease and ischemic heart disease may complicate the situation for people with diabetes, making them frailer and further increasing the severity of COVID-19 disease and the need for care such as acute dialysis. It is not that people with diabetes are more likely to get COVID-19 than the general population. There isn't evidence to indicate that if you have diabetes, you are likely to get COVID-19. That's not what we're saying or what the information that has been gathered so far says. What it says is that when people with diabetes become infected with COVID-19, then they have a higher chance of experiencing serious complications from COVID-19, and the outcomes are usually not good. And this is even worse for those diabetics who do not manage their diabetes well and experience fluctuating blood sugars. Let us also emphasize that obesity also predisposes people to many ailments, diabetes included. Many patients with type 2 diabetes are obese, and obesity is a risk factor for severe infection. People with severe abdominal obesity also have mechanical respiratory problems, resulting in poor ventilation of the lungs, thus increasing the risk of pneumonia, as well as reduced oxygen saturation of blood. With COVID-19, this combination of conditions can be deadly. Of those we have lost to COVID-19 so far, 15% of those with comorbidities had diabetes. COVID-19 deaths due to diabetes and hypertension combined account for 47% of deaths of those who had comorbidities. we have over 500,000 Kenyans living with diabetes. It is to them and their loved ones that I'm speaking to at this moment. This group of Kenyans is advised to ensure they remain safe, ensure that they eat healthy and keep their blood sugar at manageable levels. As a ministry, we are asking those with diabetes to stay home and only to go out when absolutely necessary. But even then, to wear masks and maintain social distance. And if you happen to live with someone with diabetes, you must be aware that as a potential carrier of the virus, you could very easily transmit the virus to this vulnerable group of people. So you must be your brother's keeper and make sure that you observe the containment measures that we have put in place so that you do not spread the virus to any Kenyan. You must ensure you keep high levels of hygiene, sanitize often, wear masks around them, and most importantly, keep your social distance. Let me now turn to our COVID-19 numbers for the past 24 hours. We tested 2,052 samples, out of which 375 turned out positive. The number of samples that we have tested so far stands at 268,154. And our caseload, that is the number of confirmed positive cases, stands at 16,643. From the 375 cases over the last 24 hours, 351 are Kenyans and 24 are foreigners. 229 are males, 146 are females. The youngest is an infant 5 months old. The oldest is 90 years old. The distribution of cases by counties is as follows. Nairobi, again leading with 240. Kajiado 36. Kiambu 31. Migori 16. Machakos 15. Nakuru 14. Nyeri 5. Kisumu 3. Uasin Gishu 3. Mombasa 3. Trans Nzoia 2. Meru 1. Kakamega 1. Kisii, Siaya, Vihiga, and Muranga 1 each. For the 3 leading counties, the cases are distributed by sub-counties as follows. Nairobi, with its 240 cases, registered cases in Westlands 31, Langata 30, Dagoretti North 26, Kibra 26, Makadara 19, Embakasi South 14, Starehe 13, Embakasi East 12, Embakasi West 12, Kajiado, which had 36 cases, had these distributed in the following sub-counties: Kajiado East 24, Kajiado North 8, and Kajiado Central 4. Kiambu, which was third with 31 cases, had 7 cases in Kiamba, 6 in Kiambu Town, 6 in Ruiru, 4 in Thika, 3 in Kabete, Gatundu, Juja, Kikuyu, and Lari, 1 case each. The document that you will receive will give the breakdown of sub-counties in the other counties where cases were detected. On a positive note, 128 patients have recovered from the disease. Out of this, 74 are from the home-based care program, while 51 were discharged from the various hospitals throughout the country where they were receiving care. This brings the total number of recoveries to 7,574. And again, I want to thank our healthcare workers for the great work they're doing out there. Unfortunately, we have lost 4 patients from the disease over the past 24 hours, and this brings our losses to this cumulative losses to the disease to 278. Our sincere condolences to the families and friends of those who have lost their loved ones. Finally, I want to reiterate that all Kenyans continue being vigilant as the disease still looms large in our midst. And for those who have lost their beloved ones, we send our heartfelt condolences. I thank you.
Thank you, Dr. My name is Elfas Lagat from Citizen Television, and I have just a few questions that I'll run through very fast. First, can you tabulate how many people with diabetes, heart problems, HIV, lung diseases have died as a result of COVID-19? And also, why is it that diabetes is particularly dangerous to the bodies of those with COVID-19? Any scientific explanation to that effect? And also, Dr. Kuria, you mentioned yesterday that you have teams out there and that counties have been clustered into 11 of them. And from the initial findings is that about 29% are highly prepared to handle COVID-19. Then do you have measures that you are putting in place now to ensure that public hospitals are ready to handle the surging numbers? And can you give us numbers? Can you quantify the number of public hospitals that can handle COVID-19? And also, as I finish up, is on bars, it's an open secret that several bars are operating past the curfew hours, and some of them have been raided severally, but still they operate. Are there measures that you intend on carrying out on this? And lastly, is that security guards, particularly in public installations, corporate entities, and they are emerging as the new group of frontline workers and are exposed to a higher risk of infection. Are there plans that you have as a ministry to address and help this particular group? Thank you.
Thank you. I'm Mark Namasa from KTN News. I'm still following up on the issue of payment that patients are being asked to remit at the Kenyatta University Teaching and Referral Hospital. I'm told those ones who are brought via ambulance also have to pay for it. And there is no negotiation at the reception. The nurses or the people at the reception ask the patients to pay through the pay bill number 293762, and there is no negotiation, even after the ministry announcing very clearly there will be no charges for patients for COVID-19 in public facilities. Thank you.
Thank you. I'm Purity from KBC. From the number of cases that we have so far, over 16,000, my question would be, how many people approximately have come into contact with this virus? I'm talking about the people you're tracing from the confirmed cases so far. And then the number of people that are dying, once again, it's quite high. What could be the cause? I know most of this you said, and most of these patients have underlying condition, but the management, because when the corona started in Kenya, we never used to witness such numbers being announced every day of fatalities. So is it the management of these patients, or is it most patients who have the complications of the underlying conditions? What could be the problem? Thank you.
Thank you. Alphas Lagat, I will respond to your question on these underlying conditions, and I think you had a couple of other questions which were directed at Dr. Kuria. These underlying conditions, of course, predispose one to a more severe form of the disease. And what causes this? Why do people who have some of these underlying conditions suffer the fate that we have seen, where they tend to be those who will become severe and critically ill, and in many cases they will be the ones who will succumb to the disease? Well, there are a number of things to consider. One, age has a lot to do with it, but non-communicable diseases themselves have a lot to do with it. We know very well that people who have reached a certain age, as we advance through life, most of these non-communicable diseases, we will end up acquiring these and have to live with them as chronic conditions as we age. So you already have a combination of a disease and age factor. The second thing is that non-communicable diseases like diabetes, hypertension, renal disease, and many others take a toll on one's immune response and the ability of one's body to be able to mount a strong immune response. This, on top of the fact that with age, also our bodies naturally are not able to respond in the way that you would respond when you are young. So all these factors brought together, you can see, place people who have, one, the non-communicable diseases, and then if they are also of a certain age, 60 and over, it makes it doubly complex for them to be able to deal with these diseases. So that's the reason why we are seeing some of these underlying conditions, mostly in older people, and then it takes a toll on them. Does that mean that younger people who have these conditions also do not suffer? Of course they do, because they would still suffer from the same things that I have mentioned. If you are young and you happen to have diabetes, for example, and you are not managing it well, you will suffer the same fate. The disease will take a toll on you. Now, what is the scientific basis? That I think was part of your question also. What's the scientific basis at what makes these diseases, a risk factor, when you have them, a risk factor complicating the course of COVID-19? It is known that, a fact that coronavirus, SARS-CoV-2, gains entry into cells, that it infects the epithelial cells of the lung, blood, and intestines as well, through a molecule called ACE2 receptor. This ACE2 receptor plays a physiological role. I will not get into it, but there has been suggestion that because people who have these conditions are often on medications that actually target that receptor and block that receptor, that this might result in people with these conditions, it might result in overexpression of the ACE receptor. And remember I said it's the entry point it's the docking protein for coronavirus. That is a hypothesis that that's the hypothesis that perhaps because they are on these ACE receptor blockers, that they may then therefore have a higher number of ACE receptors in their cells and therefore take in more virus. It's a hypothesis. It has not yet been thoroughly explored to determine whether indeed that is the case. But aside from that, just like any other disease, if your immune system is not working perfectly, and it doesn't work perfectly when you are either have a chronic condition like these non-communicable diseases, or you have aged, your immune system is somewhat compromised, most other infectious diseases will be able to display a serious course in people who get infected with those diseases. Okay. The other questions we will leave to Dr. Kuria when he gets to answer that. Mark Lamasa. Well, I think the position still stands that the government does not expect those who receive care in its public health facilities for COVID-19 to pay for those costs of quarantine or isolation in public health facilities. That position has not been changed. If there are reports that some public facilities are charging, it is something that the ministry will look into and establish what are the reasons. There could be some reasons that might justify that, but we will need to look into those cases and find out, are these isolated cases or is it a blanket situation where everybody who comes in to any public hospital like KTU RRH is required to pay. I think that is something we shall take up with the relevant institutions and establish why it is happening. Purity, KBC. Yeah, indeed, we have a large number now, in excess of 16,000 positive cases. Remember, we are on a trajectory. Remember that this disease has evolved along this trajectory in our country and in every country. They have their own experience and how the disease evolves. Of course, when early on we were young, we had 1 or 2 cases who happened to be imported cases, young people coming in. The situation was fairly different. We do know that most of our young people who have COVID-19 are asymptomatic. There are still a few young people who get hospitalized, and some have even died, but they are rather rare. Most of the people who are hospitalized tend to be older people, again with underlying conditions. So we have progressed through time because that has happened as soon as we switched from the importation, transmission by importation, to community transmission. Now that the virus is spreading in the community, it is likely to affect the entire cohort, age range of the country. And so when it hits older people, this is what you see. That is why we are seeing what we are seeing right now, because it has spread in the community and it will take its toll on the vulnerable and high-risk groups who, for one reason or the other, either the virus can spread faster in the situations in which they are, or their physiological and body functions are compromised, that the virus can actually cause quite a bit of damage in their systems. The deaths, you questioned, and you said that the deaths are high. We have registered, I think today we said just over 274 or so deaths so far. If you look at our case fatality rate, it stands at around 1.7, 1.1.
1.7.
Well, yeah.
But if you use the 4, it's 1.1.
Yes, so it is between 1.1 and 1.7, let's put it that way, of case fatality rate, which is actually very low compared to what we have seen in other countries, especially in the developed countries and in China, when this coronavirus, and some of them, it is still ravaging them. So in that regard, I think our fatality rates are not as high as one would think compared to other countries. But nonetheless, any death should be prevented if it is possible. I can assure you that I don't think that these deaths are due to any improper management in facilities. I think we have prepared most of our facilities on how to deal and manage COVID-19 patients, and indeed that's why we are beginning to see so many recoveries. The home-based care also is giving us recoveries. So I would say that there is nothing unusual about these deaths, and it does not point to substandard care within the facilities. I would not say that. So let me now hand over to Dr. Kuria to respond to the question from Elfas Lagat on the one about the hospitals, bars, and then the security guards. Dr. Kuria.
Thank you, Wazir Rashid. Maybe before responding to Alpha's question and maybe to Purity, the question of we are experiencing very, very more deaths. Yes, indeed, we are getting more cases. But the case fatality rate has remained fairly low. The more cases you receive against that case fatality rate, there will be that perception that you are getting more deaths. But the actual measure is that case fatality rate. But yes, indeed, you'll be recording more numbers as you record more numbers of positive cases. And what should be worrying us more actually is the rate at which the samples we are taking are turning positive. That is what is more worrying to us, not the increased number of cases that are dying, because this is due to the number of cases. But you're getting more number of cases because more people are turning positive. The positivity rate is going higher, so that for every 100 patients that you sample, 29 are turning positive in Nairobi, because that is what the figures we have today. That is a more worrying figure. Our healthcare workers are continuing to work very, very hard. And that is why the mortality, though high, is still maintained. We are maintaining a case fatality rate, because our healthcare workers are working day and night to try and reduce mortality amongst our cases. Over to Alpha's questions on the number of facilities that are ready to offer COVID treatment. I think we offered this figure the day before yesterday, and we said that there is an extraordinary summit, I think the day after tomorrow, called by His Excellency the President. And the updated figures are going to be provided of number of isolation facilities that are available. But as at the last announcement, the last summit, remember we said there were 282 facilities that were prepared by county governments in readiness for COVID treatment. And out of this, there were 12,513 normal isolation beds and 498 ICU beds. Now, when I said that there are teams going out there, they are verifying and working together with counties. When the country was opened up on 6th, we had to make sure that we are opening up a country and counties were prepared. So they went out verifying this information and working with the counties to make them more prepared. So that it's not just the beds alone, but in terms of equipment, oxygen, healthcare workers, matching all this, the preparedness, not just the beds, but total preparedness to handle COVID-19. Before that, we had one of our work streams in our task force that had done this area and had its own figures. And this had verified some of these facilities actually. So I know as we stand, there are those 282 facilities and 72 of them are fully verified by our task force. And more reports are coming to us as the groups continue working out there. And in this, out of these facilities, we told you as of today, we have 1,394 patients admitted out of all these isolation beds that are available. On the issue of bars, I think you have talked about this again here. And I stressed this on Monday, that in his address on 6th of July, I did not hear a declaration from the President that bars are to be opened. So bars still remain closed. So if bars are operating, they're operating illegally. And we mentioned here that if your bar is closed and permits withdrawn, do not blame anyone. And security agents are out there and they are nabbing most of these bars, but as we said here, we cannot police every other Kenyan. Because you close this bar, there's one behind this building that is open. We cannot have a police officer for every bar. There are too many. So it's again urging Kenyans, bars are still closed. And I said here, I think 2 days ago, that what is appalling and disheartening is actually the behavior in those bars. And I said people have thrown caution away. People are behaving in the pre-COVID ways. Masks have been thrown off, hand washing is not there, and we are urging Kenyans, if there's a time to be careful, it is now. So if you have to take your drink, what the president advised is, and actually directed, is that alcohol be sold as a takeaway, on takeaway basis. If Kenyans cannot abide by this, I don't know what will come of the extraordinary summit, but it is quite disheartening, and we are noting this also as a ministry and as a government. It is quite disheartening. Restaurants were opened so they could sell foods and open up the economy, but those restaurant owners have turned those restaurants into bars. So if those restaurants are closed tomorrow or the day after tomorrow, they have asked for that closure. I don't know what decision will be made, but the note has been taken of this misconduct of restaurant owners. And I would urge the decision makers to take very stern action against those contravening these laws. On the issue of security guards, again, guards are not exempt from any other Kenyan. And as long as they keep to the containment measures, they'll be safe. I know they have high rates of contact with the other citizens as they man entrances and doors, and gates. And what we urge of them is to maintain the containment measures as advised. And those who keep these measures are keeping safe. That simple act of wearing your mask properly is protecting you, much as you may not know. And it's not just the security guards. Those are even safer because there's someone reminding them when they're taking the temperature that please put on your mask properly. More disheartening are others like street vendors. Walk across the city of Nairobi and you'll be amazed. Walk across the markets. So as you're worried about security guards or even safer, worry about ordinary Kenyans, even those visiting bars, who are actually throwing caution out of the window. So security guards are at high risk, and we keep advising them to keep the containment measures, wear your mask, wash your hands, sanitize. And as they are taking temperatures, you have advised them, don't take your temperature from the front of an individual, take that temperature from the sides. When you are addressing people, keep your distance as you address those that are approaching you at the entrance of these buildings and compounds. So it's containment measures for them that we are keeping, and we have issued guidelines on workplace safety, that they are urging those employers to keep urging their security guards to keep employing. I think that was all that I asked.
Thank you, Dr. Kuria. I want to add to respond to Purity's question regarding the numbers in terms of comorbidities. I can tell you that when we had about 250 deaths, and that was not too long ago, when our number of fatalities were 250, we do know that 129 of these 250 had comorbidities, 129 of them. And if we look at that 149 who had comorbidities at that time when we were at 250, about 50% of those had hypertension and diabetes, not together, but when you add those two. So for instance, from hypertension and diabetes, was about 32% of those had hypertension. 15%, as I said earlier, had diabetes. So we have a table here which we can share with you that has broken down the various comorbidities of those 129. 129 out of 250 is about 50%. So about 50% of our fatalities had comorbidities of one form or another, with hypertension and diabetes being the most frequent ones. Thank you.
Gakugeithia na gakunyita ugeni thiini wa tabarĩra ĩno ĩrĩa